thank you to the Movement Disorders Foundation of Arizona to have me this evening to present on the sleep disorders. So I'm going to share my screen now. So let's review sleep quality and its impact on risk and symptoms of Parkinson's. So in sleep medicine, we actually do see a lot of individuals with sleep disorders and a lot of patients with Parkinson's, obviously. So our objectives this evening are going to be reviewing Parkinson's disease very briefly, both the motor symptoms and non-motor symptoms, the sleep disorders that are prevalent in Parkinson's disease, and then, of course, REM sleep behavior disorder, which is a very significant and common disorder that we see in patients with Parkinson's. As you're aware, Parkinson's is traditionally characterized by its cardinal motor symptoms, which can include bradykinesia, resting tremor, rigidity, and even postural instability. But it's important to note that Parkinson's actually, in fact, is a very multidimensional disease process with a myriad of non-motor symptoms that can include autonomic dysfunction, such as impaired blood pressure control, mood disorders such as depression and anxiety, cognitive impairment or memory issues, pain, GI disturbances like constipation, olfactory or sense of smell issues, psychosis, and of course, sleep disorders. So let's dive into the different sleep disorders that we'll see in this patient population. So first off, it's important to note that James Parkinson, the English surgeon that first described Parkinson's disease in the early 1800s, wrote in his essay called The Essay on the Shaking Palsy that was published in 1817 that many patients that he studied were greatly affected by disturbed sleep, in addition to motor symptoms. He wrote that he observed tremulous motion of the limbs occur during sleep and augment until they awaken the patient, and frequently with much agitation and alarm. In his description of case number 6, he wrote the patient's attendants observed movements during sleep that increased until it awakened him, when he always was in a state of agitation and alarm. So that's thought to be possibly the first description of REM sleep behavior disorder or violent dream enactment behavior. But you can see that even when Dr. Parkinson first described Parkinson's disease, not only did he discuss the motor symptoms, but he also discussed that he had noted issues with sleep as well. So you can see that there's been significant descriptions of poor sleep in this patient population for a number of years. So sleep disturbances are very common in patients with Parkinson's, with it being estimated that 60 to 90% of patients with Parkinson's have sleep disturbances, which can include both nighttime and daytime manifestations. The development of sleep disorders in Parkinson's may be the result of the neurodegenerative process itself, which can disrupt the networks regulating the sleep-wake cycle, but also deplete many neurotransmitters that possibly play a role in the initiation and maintenance of sleep. A 1988 survey noted that about 98% of individuals with Parkinson's had experienced disabilities at night or on waking since the onset of Parkinson's. Disturbed regulation of maintaining wakefulness or staying awake during the day was shown to be prominent in about 30% of individuals with Parkinson's. Common sleep disturbances in individuals with Parkinson's are very similar to the general population. They can include insomnia, which is defined as either having sleep initiation or sleep onset issues, sleep maintenance or difficulty staying asleep, early morning arousals, which are usually waking up in the early morning hours like 2, 3, 4 o'clock in the morning, or non-restorative sleep that can result in daytime functioning impairment. Daytime manifestations can include excessive daytime sleepiness, but even sudden sleep attacks. Also sleep apnea, restless leg syndrome, periodic limb movement disorder, circadian rhythm disorders or disorders of the internal clock, which can be advanced sleep phase disorder, where an individual may go to sleep at 7 p.m. and wake up at 3 a.m., or delayed sleep phase disorder, which is in those individuals that are night owls that may not go to bed until 3 a.m. and wake up at 10 a.m. But then even parasomnia behaviors, which are abnormal behaviors during sleep, which can include both non-REM, which are activities that occur outside of REM sleep, which is where we dream. That can include sleepwalking, or those abnormal behaviors that occur when we dream, such as nightmares or REM sleep behavior disorder. And it's important to note that disrupted sleep can affect the health, mood, and overall quality of life of individuals with Parkinson's. Like I said, I have many individuals with Parkinson's that have sleep issues, and I've met many patients that have noted worsening of their motor symptoms or their mood when they're not sleeping well. But when they're getting better quality sleep, they definitely have noted improvements in their overall quality of life, both because of improvements in their motor symptoms, but even their mood and just overall the way they feel. When individuals with Parkinson's don't sleep, well, their caregivers also have poor sleep as well. And that's important because these individuals do need good quality sleep to be able to remain healthy, but also to assist the individuals with Parkinson's as well as they can. So poor sleep in individuals with Parkinson's just doesn't impact them, but it also impacts those around them that take care of them. So let's discuss more detail about insomnia. So insomnia is the most frequent sleep disorder in individuals with Parkinson's. The most frequent complaint usually is sleep maintenance insomnia with difficulty staying asleep, with frequent nighttime awakenings and sleep fragmentation. But then also you can have onset insomnia, which is difficulty falling asleep, or terminal insomnia, or early morning arousal. The risk factors for developing insomnia in individuals with Parkinson's can include the neurodegenerative process of Parkinson's itself, female sex, the length of time the individual's had Parkinson's, having a history of depression or anxiety disorder, but also being on dopamine agonist, but also the withdrawal of these medications as well may trigger insomnia. How do we evaluate patients with insomnia in sleep clinics? So first, we want to determine the subtype. Are they having problems falling asleep, staying asleep, early morning arousal? But then we also want to rule out sleep disorders that can present with symptoms of insomnia, such as restless leg syndrome, periodic limb movement disorder, sleep apnea, RBD or REM sleep behavior disorder, or even circadian rhythm disorders, as I mentioned earlier. The majority of Parkinson patients we see typically in our sleep clinics do have a nocturnal sleep disorder that's triggering their insomnia, whether it be sleep apnea, PLMD, restless leg syndrome, or even RBD, which is very common. How do we treat these individuals? So the main treatment for pure classical insomnia is going to be cognitive behavioral therapy for insomnia, or CBTI, which is a form of cognitive behavioral therapy that's typically performed by clinical psychologists. And we actually have a clinical psychologist, Dr. Kelly Creech, in our practice, who's a sleep psychologist that specializes in this specialized form of therapy. But studies have also suggested that even long-acting levodopa, carbidopa can improve sleep-associated motor symptoms that may improve sleep quality, that may disrupt sleep. Another common issue in patients with Parkinson's is actually nocturia, or frequent nighttime urination. This is a common disruptor of sleep and may affect up to 35% of individuals with Parkinson's. It's thought to possibly be related to changes in automatic bladder control, but it's important to rule out and treat secondary causes of frequent nighttime urination, such as sleep apnea, which is a very common cause of frequent nighttime urination, urinary tract infections, enlarged prostate in men, history of heart failure, but even anxiety. Also, it's important to optimize dopaminergic therapy, but also behavioral interventions are also very important, such as reducing fluid intake prior to bedtime, but then even avoiding diuretics or medications that would cause us to want to urinate more prior to bedtime. Now, restless leg syndrome. So restless leg syndrome can affect at least 15% of individuals with Parkinson's. The prevalence increases during the course of Parkinson's and the treatment duration. Individuals with RLS do have an older age at Parkinson's onset. They do report a worse sleep quality and have more cardiovascular anxiety disturbances. Iron deficiency may play a role, and as such, we want to keep the ferritin, which is a long-term marker of iron storage, greater than 75 nanogram per ml for optimal dopamine synthesis. Withdrawal from dopaminergic agonists, antihistamines, and antidepressants may also trigger RLS symptoms. Individuals with restless leg syndrome typically complain of problems falling asleep because they experience this sensation of either pain, discomfort, or even sometimes a creepy crawling sensation when they're laying in bed, usually in the lower extremities, and movement triggers improvements in the symptoms, but then these individuals are forced having to get in and out of bed constantly to be able to alleviate these symptoms, and eventually hours go by before they're able to actually fall asleep. Another common condition that we see is periodic limb movements. These are stereotypical and repetitive movements affecting the limbs, particularly the legs, which can trigger arousals and disrupt sleep. They're very subtle movements that we typically detect during a sleep study, and most individuals that have these movements don't know they're doing because they're asleep, but even their bed partners won't notice them either because they're not necessarily full-on kicks that one would see like in REM sleep behavior disorder. But they're commonly associated with restless leg syndrome, very commonly associated with untreated sleep apnea, and they can also be present in patients with narcolepsy. About 80% of individuals with restless leg syndrome do have these movements, but not necessarily PLMD, which is a sleep disorder caused by these movements. Parasomnias, like I mentioned earlier, are abnormal behaviors during sleep. They can be non-REM sleep parasomnias, which are those that occur at a stage 3 sleep, which is a deep level of sleep that typically occurs in the first third of the night, usually sleepwalking. And then REM sleep parasomnia, which are those that occur at a REM sleep, which is where we dream. Could be nightmares or REM sleep behavior disorder. Non-REM parasomnia activity could be sleep talking or sleepwalking. Individuals with Parkinson's and RBD do have a higher incidence of non-REM parasomnia activity, which is referred as parasomnia overlap disorder, which would be a combination of both RBD and sleepwalking. Sleepwalking with Parkinson's disease is associated with a higher incidence of depression and even advanced Parkinson's stage. It is important to rule out underlying sleep apnea or periodic limb movement disorder as a potential source of stage 3 sleep arousals, as a treatment approach would be to treat the underlying sleep apnea or the PLMD. Usually individuals that have sleep talking or sleepwalking as adults, there's usually a reason for it. Most commonly ends up being sleep apnea, triggering the brain to wake up in stage 3 sleep and precipitate these events. But in those individuals that don't have a sleep disorder that's identified that's triggering these arousals, then may consider medication treatment to help treat these movements or behaviors. Now, REM-related parasomnia behaviors, like I mentioned, nightmares, estimated to be present in approximately 20% of patients with Parkinson's, could be secondary to underlying RBD. And then, of course, REM sleep behavior disorder, discuss in more in depth in the next few slides. Before we get to RBD, let's review sleep apnea. So sleep apnea is quite common in patients with Parkinson's and estimated to be as high as 60%. Majority, if not all of my patients with Parkinson's actually do have underlying sleep apnea. And treating them successfully actually has resulted in significant quality of life improvements because they're able to actually stay asleep through the night. The frequent nighttime urination settles down quite dramatically. They're actually waking feeling rested, but also it's resulted in significant improvements in even the REM sleep behavior disorder activity. There does not appear to be a causal relationship between Parkinson's and sleep apnea, meaning there's no relationship established where Parkinson's disease may cause the individuals to develop sleep apnea. But it's documented that sleep fragmentation and the repetitive drops in oxygen can or may contribute and worsen Parkinson's. Treatment options for sleep apnea, as you're probably aware, is CPAP therapy, which is a gold standard. Then there's a mandibular advancement device, which is an oral appliance that a dentist makes that helps to extend the jaw forward. And then the newest therapy is actually an implant called hypoglossal nerve stimulation, or Inspire, where it's a little 2-inch implant that ENT places in the right upper chest. And then there's an electrode that's cuffed around the nerve that controls the tongue. And you basically, when you go to sleep, you take a remote, activate it, and with each inhalation, it actually helps to move the tongue forward. So it proactively prevents the throat from collapsing or prevents the sleep apnea from occurring. I actually do have one patient right now who's actually a first in the world who has a deep brain stimulator. She's got Parkinson's, she has a pain pump, and she has Inspire as well. But hers is placed on the left chest because she has a DBS on the right. But she's actually doing extremely well. I believe she's 76 years old, and she went from waking 6 to 8 times a night to go to the bathroom, falling asleep in the morning while having a breakfast, to sleeping about 8 hours through the night with rarely waking to go to the bathroom, waking rest in the morning, staying awake throughout the day, not falling asleep, just purely by treating her sleep apnea successfully with the Inspire device. So a really remarkable story. So excessive daytime sleepiness, again, is a very common issue as well. And approximately 21% of patients with Parkinson's will have reports of excessive daytime sleepiness or problems staying awake during the day. And it can increase as the disease progresses. Common contributors to excessive daytime sleepiness in Parkinson's can be age, sleep-wake cycle alteration related to neurodegenerative process of Parkinson's, the presence of sleep disorders such as periodic limb movement disorder, sleep apnea, daytime immobility, dopaminergic medications. And treatment can be challenging, but it's important from our perspective as sleep specialists to treat all underlying sleep disorders first and remove any medications that may contribute to EDS or excessive daytime sleepiness. And truth be told, majority of my patients with Parkinson's, once we treat their underlying sleep issues successfully, most of the individuals have very minimal complaints of daytime sleepiness, which is great. So we don't really have to do anything further in terms of helping them to stay awake during the daytime, but just making sure they're getting plenty of sleep and good quality sleep. So some initial steps for improving sleep. The simplest way to start sleeping better with Parkinson's disease is by adopting healthy sleep hygiene. So sleep hygiene tips for Parkinson's disease sufferers include sticking to regular bedtimes, following a consistent bedtime routine with soothing activities such as listening to music or reading a calming book, getting regular exercise, preferably early in the day, getting adequate exposure to light, whether outdoors or through light therapy, avoiding long naps and naps late in the day, which can affect the sleep drive and cause an individual not to be able to go to sleep at night. Creating a cool, dark, and comfortable sleeping environment. Restricting bedtime activities to sex and sleep only. Turning off screens an hour before bedtime. Reducing liquid intake before bedtime to avoid the frequent nighttime urination. Avoiding caffeine, alcohol, and tobacco. But also eating a healthy diet and avoiding large meals at night. So now let's discuss REM sleep behavior disorder more in depth. So RBD is characterized by the persistence of muscle tone during REM sleep, which we call REM sleep without muscle atonia. So a characteristic feature of REM sleep is that all skeletal muscle is paralyzed. So we should not be able to move when we're dreaming, and nor should we be able to speak or verbalize what we're actually saying in our dreams. So in RBD, there's a loss of that skeletal muscle paralysis, but then also the condition is accompanied by both motor and behavioral activity and then dreams as well. The condition is usually prominent in males. It usually emerges after the age of 50. The dreams in RBD are often described as being quite violent or unpleasant, with patients reporting aggressive dreams of being attacked, having to protect themselves, or usually physical with or without verbal altercations. Usually very action-filled dreams that can cause the individual significant stress, as the dreams are very atypical to their overall daily lives. The individuals usually wake abruptly with complete coherence, meaning they're completely aware of what was going on, and they're fully able to describe the dream and describe exactly what was going on. And their bed partners are able to actually make sense of what they're describing in their dream, because that's actually what they were seeing and observing the individuals do while they were dreaming. Common behaviors in RBD most commonly are going to be violent, such as punching, kicking, thrashing, even leaping out of bed. Less common can be talking, including giving speeches. And one thing that differentiates RBD between classic sleep talking is that most individuals that have sleep talking, their speech is kind of garbled. It's hard to make out what they're saying, but individuals with RBD, you can completely make out what they're saying. It's almost like the person's awake talking to you. And I just had a patient in clinic earlier this week that I met for the first time, and that was one thing that his wife said, that whenever he has this activity, you can completely understand exactly what he's saying. In fact, one of the episodes was him giving a speech at a conference, and he was able to tell his wife that he was at a specific conference giving a lecture. Also, other behaviors can be smiling or laughing, singing or whistling, shouting, swearing profanities, crying, chewing, grabbing, arm flailing, sitting up, crawling or running. And rarely it could be smoking a fictive cigarette, masturbation-like behaviors, pelvic thrusting, then even mimics of eating, drinking, urinating, even defecating. And I've honestly, in the last 10, 11 years, I've had patients report pretty much every one of these behaviors. But it's also important to note that when individuals are having RBD activity, their eyes are usually closed. And that's also a differentiator between sleepwalking. In sleepwalking, the individual typically looks awake, but their brains are asleep. But in RBD, the eyes are fully closed. So diagnosis of RBDs typically includes both a clinical history of having violent dream enactment behavior, but then also sleep study is going to be important, because there are specific things that we have to look for during the sleep study, including the loss of skeletal muscle paralysis during REM sleep, but then also possibly capture on video some of the dream enactment behavior. The course of RBD is usually gradual, but occasionally it can present with really rapid onset. But then over the course of the years, it's usually a very progressive condition. So we always have to reevaluate and monitor these individuals very closely, because once they're stable, it doesn't mean that they're going to be stabilized for the rest of life. It can periodically change, so where we may have to reevaluate. When does RBD typically happen? So it usually follows our dream cycle. So if you look on this hypnogram here, which actually is how we look at sleep once we score the brain activity, the red bars you can see are the times that's when we dream. So as the night progresses, you can see that the red bars get longer, and usually the red bars are where we dream. So usually RBD behavior typically occurs more commonly in the second half of the night. That's the time that we spend the most amount of time dreaming. But it can technically occur as soon as 90 minutes after the individual initially falls asleep. And in individuals with narcolepsy, a differentiator of narcolepsy individuals is that their brains have a tendency to go into REM sleep very rapidly. So very rarely the RBD behavior may occur soon after sleep onset. But like I mentioned, most individuals will report this behavior in the second half of the night, usually 2, 3, 4 in the morning. So this video here I found actually is a very nice presentation individuals present to the sleep clinic. So I'd like them to be able to watch this.
Violent, uncontrollable dreams, startling spouses, and leading to painful injuries. They are the result of a condition that's often misdiagnosed. Health reporter Haley Hernandez reveals what causes the condition and the medications that can be used to treat it.
Orvis Rig Rigsby and his wife Karen loved theater and travel.
He was a theater professor and I was a theater person, so for me it was really, there was a immediate connection, and we had a similar sense of humor, and it was just a lot of fun.
But just a few years ago, Rig started showing signs of dementia.
He had an incident where he got very disoriented and lost in our backyard, and that's when we started looking for help from a neurologist.
At first, Dr. Ira Goodman thought Rig had Alzheimer's disease.
And actually, I'd initially referred him for a clinical trial for Alzheimer's disease, but right before he entered, I changed my mind.
Instead, Dr. Goodman diagnosed Rig with Lewy body dementia and REM sleep behavior disorder. The condition, seen here during a sleep study posted on social media, causes a person to act out violent dreams.
There have been fractures, there's been subdural hematomas, and as far as spouses or bed partners, there's been reports of up to 2/3 of bed partners being injured during an episode.
Sometimes he would just start yelling, or sometimes he would start punching around. Sometimes it was like he flew off the bed.
Currently, there is no cure. Rig wears a patch that helps ease the symptoms, but keeping a watchful eye is the best defense.
If he's having a bad night, I'll sleep in the bed with him and hold my hand on his shoulder.
Dr. Goodman and Karen Rigsby say not to be afraid of getting evaluated if you notice any symptoms.
I tell everybody, don't waste time, don't waste time, don't wait, don't wait, don't wait. That's all you can say.
A clinical trial is underway for a new drug called nilotanserin to treat the REM sleep behavior disorder. Klonopin, an anti-anxiety drug called clonazepam in the generic form, is most commonly prescribed, but it has side effects. Another option, the dietary supplement melatonin. Haley Hernandez, KPRC, Channel 2 News.
So that was a very classic presentation of when patients come in with their spouses when they first describe RBD type behavior. So what are the clinical implications of RBD? Why am I spending time reviewing RBD? So RBD is actually strongly associated with alpha-synucleinopathy degeneration. So there are several lines of evidence that indicate that RBD can be a prodromal form or precursor to synucleinopathy, which is the category of conditions that Parkinson's, dementia with Lewy bodies, or multiple system atrophy is within. So an autopsy series of individuals with RBD found underlying synucleinopathy in 94% of these individuals. Even tissues such as skin biopsies that are being performed now, that Dr. Evidente performs, from living individuals with RBD have demonstrated the presence of abnormal alpha-synuclein protein, suggesting that RBD itself is a synucleinopathy that can occur many years before Parkinson's develops or the other conditions develop. A large cross-sectional study of 171 RBD patients also found that 74% met Movement Disorder Society criteria for a diagnosis of early Parkinson's disease. So long-term studies of individuals with idiopathic RBD have shown consistent evidence for a strong association with eventual progression of Parkinson's, non-amnestic mild cognitive impairment, dementia with Lewy bodies, or multiple system atrophy. So the overall progression risk of developing one of these conditions when the individual is diagnosed with RBD is within 2 to 5 years is 15 to 35%. The risk over 12 to 25 years increases up to 41 to 91%. But specifically in the Parkinson's disease group, individuals that are diagnosed with RBD today, about 25% will develop Parkinson's symptoms in about 5 years. About 50% will develop Parkinson's symptoms in 10 years. 75% will develop Parkinson's in 25 years, and about over 90% will develop Parkinson's in 30 years. So there's many individuals I see in clinic that I diagnose with RBD in their early 50s, and I have to tell them and counsel them that, hey, there's a risk that over the course of the next 5 to 30 years that you will highly likely have Parkinson's disease. So as a result of it, it's very important to know about this condition, these symptoms, because it can develop many years before the initial symptoms of Parkinson's may actually develop. So what is the relationship between RBD and Parkinson's? So it's thought that the initial neurodegenerative process that occurs in the brainstem where Parkinson's develops results actually initially in the development of RBD. And as the degenerative process progresses, that's when the symptoms of Parkinson's begin to emerge. So even clinical assessments of even color vision and even smell or olfaction in patients with RBD can predict the development of Parkinson's. So RBD patients with impaired sense of smell or olfaction have a 35% chance of remaining disease-free or free of Parkinson's for 5 years, compared to 86% chance of not developing Parkinson's if they have normal sense of smell. And then RBD patients who have problems with object identification have a 5-year disease-free chance of only 18%. So you can see that about 82% of individuals with RBD that have problems with object identification will develop Parkinson's over the course of 5 years. So this paper here actually just shows that the prevalence of RBD in Parkinsonism does increase with age. And the data on the right shows that RBD was present in nearly 77% of patients with Parkinson's, 89% of patients with dementia with Lewy body, and 92% of patients with multiple system atrophy had RBD. And the prevalence rates were similar between both males and females. So treatment, how do we treat RBD? So first off, very important is going to be counseling. So bedroom safety principles to prevent injury or serious consequences should be implemented right away, including lowering the mattress to the floor, placement of cushions or pads adjacent to the bed to minimize injury during falls, bed rails, padding sharp corners near the bedside, removing all sharp objects, removing firearms. And in some cases, we do have to advise the bed partner to sleep in a separate bedroom, depending upon how injurious the behaviors are and how injurious the behavior is towards the bed partner. But also avoidance of significant alcohol consumption and abuse and withdrawal are very important as well, because alcohol can trigger RBD activity. I have one patient who has found that just having a single glass of wine at dinner will cause his RBD activity to flare. Even having desserts, he's noted, has caused his RBD activity to flare. So unfortunately, he's retired, but he can't drink wine. He can't have even a dessert because that all affects his RBD behavior quite significantly. So apart from being treated for sleep apnea and being on melatonin, he noted that these other things also are important in his situation to minimize any RBD activity. But then treatment of comorbid sleep disorders also is very important. So majority of my patients that I see that have RBD do have comorbid sleep apnea, as well as possibly periodically a movement disorder. And I have many individuals with RBD and sleep apnea that just treating their sleep apnea alone with CPAP has stabilized their REM sleep, so their brain is able to get into the appropriate amounts of REM sleep the way it should. And this in turn has actually allowed the RBD activity to settle down quite dramatically to the point where they don't completely stop having activity, but the violent behaviors basically almost always go away. They may still vocalize a little bit, may have a little bit of twitching, but that's the extent of it. So that's very important. So improving their sleep is actually very critical. And then some individuals over time, they may start to progress. So even initially, once we can control their sleep, improve their sleep, their RBD activity may be settled. But then as I mentioned earlier, the RBD can actually progress over time where we do have to then intervene with some medication option. So there's two main pharmacological treatments. So first is going to be melatonin. So we always start with melatonin first. And melatonin obviously is a better option in individuals with sleep apnea because it doesn't cause upper airway muscle relaxation. And it's thought to increase the skeletal muscle paralysis during REM sleep that is characteristically lost in patients with RBD. One thing that I do is I usually will prescribe, or not prescribe, but recommend extended release melatonin, just so it can last longer into the second half of the night. Because as I showed on that graph earlier, we spend more time in REM sleep in the second half of the night. So if we can use extended release melatonin to go into that second half of the night, then it can help to better stabilize and prevent the RBD behavior. And in individuals that melatonin alone, in addition to treating underlying sleep apnea or sleep disorders isn't sufficient, then we will have to consider clonazepam, which in the video the reporter discussed. So clonazepam, which is a benzodiazepine, is an addictive medication. We prefer not to use it first line if possible, but it doesn't work by increasing the skeletal muscle paralysis, but it's actually thought to actually help to reduce the violent dreams and even the complex motor behaviors. But the issue with it is that it can exacerbate comorbid sleep apnea, especially if it's not being treated, but it can even affect cognition or memory as well. But we often do use it synergistically at low dosages with melatonin if melatonin alone doesn't work. But then also it's important to make sure that we evaluate other medication options or other medications that the patient may be on that could be aggravating RBD behavior, such as antidepressants, mirtazapine, beta blockers, even tramadol. And we want to look at the whole picture altogether, including diet and all that, to make sure that there aren't other factors that could be actually contributing to the RBD behavior. So as you can see, RBD is quite a significant condition that can predate the symptoms of Parkinson's by up to 30 years. So in summary, individuals with Parkinsonism are at a very high risk of having underlying sleep disorders. I hope I was able to give you a nice outline of the different sleep disorders that individuals with Parkinson's can have. And we honestly see all these conditions quite often in patients with Parkinson's, but they are treatable and they don't always require medication. But the nice thing is once we can treat these individuals and improve their sleep, they actually do demonstrate significant improvement in their quality of life. I mean, they come in happy. They're not as distressed about their diagnosis of Parkinson's. It's really remarkable. And, they notice that their motor symptoms have, subsided. Medications that are being prescribed by neurologists, seem to be more effective. I even had one patient I remember distinctly who came in with concerns about sleep apnea. We put him in the sleep lab. We observed him sleep for the first 2 hours to see if he had sleep apnea, and sure enough, he did. So we initiated CPAP that same night and actually slept really well objectively. But one of the things that he mentioned to me on follow-up after his sleep study was the morning that he woke up after having slept with CPAP only for about 3 or 4 hours, when he got up that morning in the sleep lab, he could tell that his movements were much better. Like, it was easier for him to get out of bed and take that first step compared to the way he'd been feeling before he'd even used CPAP for those 3 hours. So he was extremely excited just at the fact that it was easier for him to get out of bed physically by virtue of having, treated the sleep apnea for those few hours. And then, as I've discussed with regards to RBD, early identification of individuals with RBD can definitely enable earlier screening of those that are at risk for developing a future alpha-synucleinopathy neurodegenerative disorder, which may allow for earlier intervention with therapies that may slow progression of Parkinson's or other neurodegenerative disorders. My protocol, my practice has always been that if I identify a patient that has RBD, both clinically and during the sleep study, I usually always refer them over to neurology for early evaluation. And, there's some concern about, are we scaring these individuals too early? And my thought process is I think it's important for the individual to know that, hey, there is a risk that this may occur down the road. And it's important, and I do work quite a lot with Dr. Evidente. And now that there's the skin biopsy that's being performed, as well as a DAT scan, it's been nice for these individuals to know whether or not they're headed down their path or not, but they're actually relieved to know that, all right, there's not something, unexpected happening. They're mentally prepared for it. And it's very infrequent that these individuals that had no symptoms of Parkinson's, that I explained to them that, hey, there's a risk that this may happen, that they actually, become distraught about it. So it's, if anything, they're appreciative of the fact that we get them in and get them properly evaluated and set up to where if something happens, they can be quickly intervened upon and help to minimize the long-term progression. So I hope this talk was informative and helpful, and would like to take any questions.